Hey, good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. Hey, today we're focused on a very common, very survivable diagnosis and something that I was diagnosed with a few years ago, prostate cancer. An estimated 1 in 8 American men will get it, according to the American Cancer Society. But you may not realize that prostate cancer is not one single disease, and because of that, there's not one treatment, because it's too many different kinds of diseases. There are a range of options, and today we're going to have that conversation. We have one of the world's top doctors in prostate radiation here with us today. Dr. Ron Chen is the chair of our Radiation Oncology Department at the University of Kansas Cancer Center. He helps write guidelines for national groups like the American Urological Association and the American Society of Clinical Oncology. Also joining us is my doctor. Dr. Will Parker is a urologic oncologist focused on prostate cancer and the surgical approach to that cancer. He'll tell us about a relatively new approach to prostate surgery. And full disclosure, as mentioned, he is my doc, and he is one of those top docs. Thank you both for being here. It's delighted, although I got to say one thing. I'm not sure, I saw Dr. Parker yesterday at clinic, and he walks in, I'm like, holy cow, have you been a hermit? Where were you living for the last few months, brother? Oh my God, what happened to you here?
Lost my razor. I couldn't find it, and lo and behold, here it is.
Does your wife appreciate that you've lost your razor?
She's reluctantly now on board with the beard, so it's here to stay.
Okay, it is here to stay.
Here to stay.
That was a brave. Now it stops right here, though. What happened above?
I can't grow hair on my head, so it's just a clear delineation.
Okay, there we go. All right. We're also joined by two of our awesome nurse navigators, Kathy Edwine and Sarah Gregory. Kathy works on the prostate cancer team. Sarah works on the proton center team. They're both inside the proton therapy center this morning. Team, thanks for joining us here on the program. Now, I have a question. Sarah, can you identify yourself? I don't think they can hear us. Okay, I'm going to come back to you guys. So, Sarah, we want to make sure everybody knows who's Kathy and who's Sarah, and make sure I said their last names correctly. We'll come back to that in just a moment. Dr. Chen, tell us why prostate cancer is so common.
Actually, we don't know.
That's not an answer those of us happen to want to hear, Ron.
That's the truth. I think prostate cancer is very common, and we know that prostate cancer is a disease that's more common as men get older. And in fact, actually, there's been some interesting studies to show that, as men get into the 60s, 70s, and 80s, most people will die from some other cause, whether it's cardiovascular disease or something else. But if you do an autopsy, older men are likely to have a little bit of cancer in the prostate. So it's something that happens with age. I think the prostate turns bad. But the exact causes we don't really know. Now, a lot of men, when they come to clinic, ask, well, is it inheritable? Is it genetic? Is it passed down from generation to generation? Actually, the inheritable genetic forms of prostate cancer only account for about 10% of all the prostate cancer there is. But the vast majority, we just don't know, and it just happens with older age.
So we're going to come back to that. I want to talk more about that, because what it sounds like is that your warranty on your prostate runs out around age 50 or 60, and after that it's just kind of all downhill, right? It gets too big, it has cancer in it, it gets in the way of things. So the American Cancer Society suggests men talk to their doctor about screening beginning at age 50. Tell us what that means.
So there's different guidelines out there, and they all have a slightly different age cutoff. I like the American Cancer Society one. I think it says that for men who are at average risk, and we'll talk a little bit about that you should start thinking about prostate cancer screening at age 50. For men who are at higher risk means if your father had prostate cancer, if your siblings have prostate cancer, if you have a strong family history, it should probably start below age 50, maybe even 40, 45. We also know that Black men have a higher risk for prostate cancer, and they're a higher risk too. So for higher risk men, strong family history, Black men, we should start thinking about prostate cancer screening at 40, 45. For average risk men, everybody else, according to the American Cancer Society, age 50 will be appropriate.
Okay, and so Dr. Parker, we talk about this a little bit, and we talk about how it can be different diseases. First of all, what are some of the screening things we're suggesting people have done? Because that could mean a digital rectal exam, right?
It does mean a digital rectal exam.
Yeah.
So screening for prostate
That's
cancer.
a lot of fun.
It is.
You've never had one. What a blast.
You know, the urologist handshake is part of that
Oh,
visit. So,
yeah, that's it.
No,
Okay.
so, you know, unfortunately, prostate cancer screening does involve an exam. Most things in medicine involve some, you know, hands-on component, and the prostate is an organ we can actually put our finger on and feel, and some men are diagnosed with cancers that we can palpate or can actually detect by an exam. But most of screening is just a blood test, just a simple PSA blood test, easy to do, you know, as long as you're not afraid of needles, quick and done.
But you know, there's been all this controversy about whether we should be doing PSAs, not doing PSAs. Just so where do you land? I'm going to start with you.
All right, so, you know, there is a lot of controversy about PSA. PSA, if you look back historically, was somewhat misconstrued as being the diagnostic test for prostate cancer. And it's not a diagnostic test. It's a screening tool to help us understand the risk of prostate cancer. And when you think about it in that context, it's actually a really good tool and a good test to use. Information is information, and it can add value. The danger comes if you're using that information inappropriately.
So how do you decide when prostate cancer, well, first of all, talk to me a little bit about the different types of prostate cancer. We mentioned that before, and I'd be kind of like curious about both of your angles on that, because it's not one disease.
It's not one disease. Now, prostate cancer as a whole is termed adenocarcinoma, so it's a glandular cancer. There are two subtypes of prostate cancer, but the vast majority of them are one type. Where the complexity comes in is that prostate cancer is a graded disease. So not all prostate cancer behaves the same, and it exists on a continuum from disease that's very low risk and non-aggressive to disease that is much more aggressive and much more likely to cause lethality, to kill men if left untreated.
So you and I, we're watchfully waiting my prostate cancer and hoping that it's not a problem, and so far so good. It's been about, I think, like 5 or 6 years, something like that, and it's been good. What does that mean in the long run?
So active surveillance are monitoring low-risk prostate cancer. For most men, that's all it is. It ends up just being like high blood pressure, diabetes, routine health maintenance. We're checking blood work, doing routine exams, but it's not anything more invasive than that. It's more staying, you know, proactive, preventative, and trying to avoid the harms of treatment for men who can safely avoid that.
Dr. Chen, how fast this whole cancer thing's developing in somebody, does that affect how you think about the radiation therapy?
Absolutely. I think as you and Dr. Parker had mentioned, there's a range of prostate cancer. There are some that are very slow growing where we may not need treatment, active surveillance, as you just mentioned, all the way to the other extreme where the cancer is very aggressive and has already spread. And of course, within this whole range where we don't need treatment to the cancer is spread, the treatment really differs. And so when we think about radiation, when we think about surgery, when we think about other treatments like hormone therapy, really depends on how aggressive the cancer is, and we design the treatment individually for each patient's cancer.
All right, so you see your urologist or you see your primary care doctor, you have a screening perhaps there, maybe they're doing the PSA level, things get a little bit elevated, and the next referral is to you, is that right?
That's correct.
And then what are you going to do when you first see patients with prostate cancer?
Well, with prostate cancer, I mean, but if they have a diagnosis, so we've established that there is a cancer diagnosis, the next step is going to be to really evaluate the full picture. So as a spectrum of disease, as Dr. Chen said, we really need to understand the extent of the problem. So beyond the grade that I mentioned, imaging things to understand, are we dealing with a localized problem that we treat with curative intent, or are we dealing with a disease that is already metastasized where we really need to try to control the problem? And then it comes down to this very complex thing called shared decision making, which is where we sit down and we go through this myriad of options that are available to men, which largely have similar outcomes in terms of cure, but very different outcomes in terms of the logistics of treatment and the side effects of those therapies.
All right, so when we start trying to talk about treatment options and things like that, you have to realize the very first step is to get in to see a cancer specialist, and you want to see the folks who really experience this kind of world all the time. And that involves our navigating team. And we have a couple of great folks here who are going to talk a little bit about that. Sarah Gregory and Kathy Antoine are standing by in the Proton Therapy Center. We want to hear from these two outstanding nurse navigators. First, Sarah, Help us understand what a nurse navigator does for patients.
Yeah, as a nurse navigator, our biggest goal is to decrease timeliness. Oh, can you hear me? As a nurse navigator, our biggest goal is to decrease the time from diagnosis to treatment for patients. And that all starts with our first phone call from a disease-specific navigator to a patient. We'll assess any barriers to care and help set up supportive services for that. We'll help them get any testing needed and set up prior to a meeting with all their specialists and get that set up for them as well. An important part is it's one contact person for them to help them arrange their care and make a plan for treatment and to really be a resource for them and to decrease that time. And that way when they come into clinic and they meet those doctors for the first time as well, that doctor's ready. They know the patient. They have the images. They have everything they need to really take the best care of the patient possible. And to, we spend a lot of time talking with these patients and try to ease their anxiety and their worries with, getting treated for their diagnosis.
Kathy, you've been working with prostate cancer patients specifically. What type of concerns do you hear about from patients around their cancer?
Great question. Actually, what really happens is many of our referrals for prostate cancer are self-referrals, and those patients are trying to determine what steps they want to take to treat their prostate cancer. And there's many treatment modalities where if you start out in surgery or if you to do radiation. And what we do is we talk to them about those, and then what we can do at that time is set them up to see the appropriate provider. They have great questions. Most times they're not sure where to go from here because they've had a family member that's had an experience and they think that's going to be their experience. But once we're able to talk to them and get them set up with that provider, they're more comfortable and they move ahead with it, usually, hopefully, no issues.
All right, that sounds like a really big help for somebody, especially when they get these kind of diagnoses and they're scared. Sarah, working on the proton side, tell us what kind of questions you're getting about proton therapy.
I think we get a lot of times a call from a patient that is getting current treatment and it's not proton, and their biggest concern is, do I need to get to KU right away for proton? I've read it's the best, I've heard it's the best. And it's having an educated conversation with that patient and, if needed, encouraging them to get a second opinion with a provider at KU that can have that conversation with them. And then a lot of patients want to know about insurance coverage. And I think it's important for them to know that we have a dedicated financial advisor for proton that knows their policies, knows the ins and outs of them, and importantly knows the appeal process if needed for helping with proton coverage. And those are definitely the top two questions that I get from patients.
Okay, Kathy, tell me, what's the most gratifying part of your job?
The patients. It's an awesome thing. And as Sarah mentioned, we have like our financial counselors, but we also have other treatment supportive therapies that we have available for these patients. And when you get the opportunity to sit down and talk to them about their challenges of how they've started in this process or how they're just maybe lacking, we're able to point them in the right direction. Not only do we get to know the patients, but we get to know their families. And many times after we've assisted with their care, we get calls back thanking us, we get letters thanking us for what we've done, and that's the most gratifying thing for me.
Yeah, that's a big deal. Sarah, how about you?
I would say, along with Kathy, it's that relief that you hear from a patient the moment that you have a plan established. Any diagnosis is scary, especially when you don't have a plan. You don't know the next step, you don't know the doctors. And I think that relief they get to know that we can get them set up with everything needed, and it can all be in one spot. So to know I'm, bringing them into a place that has comprehensive care with everything they need is the best part of the job.
Ron, you had something you wanted to add, I think.
Yeah, I think it's relevant to the navigation. I think one of the things that's really important when somebody has a cancer diagnosis, I think some patients, once you hear the word cancer, you feel like you have to rush into treatment right away. I think something that I think we try to emphasize is the importance of a second opinion. You want to talk to a cancer specialist that focuses on your particular cancer. You want to hear about the different treatment options that are available. And getting a second opinion, I think, is really important to make sure that the patient makes the right decision on the best treatment for them. And so for patients who are interested in second opinion, our nurse navigators really take care of that. You just have one phone call. Our nurse navigation team will match you with the right specialist for your cancer, and you can get a second opinion usually within a few days. And so I think taking that step, working with our navigators, getting to the right expert for a consultation is really important.
Yeah, I'll tell you, the navigators make a huge difference. So thanks to you all. I know when I send patients, and I've referred a number of patients to lung cancer and other things, and they so appreciate that relationship with that navigator. And what these guys do is they perform miracles to help get people in, get seen, get all the care organized, and make sure that people move through and know that they have a partner in that process. So thanks to you all for what you do. Well done. That's awesome. All right, Dr. Chen, part of your work is in proton therapy. Talk to us about why does this work for prostate cancer? Is that for all forms of prostate cancer? And when do you do other kind of standard radiation? And how does all that go together?
Well, I think we've talked about it on this program before, but proton therapy is a type of radiation that, compared to regular radiation, is able to cut down on the dose to the surrounding organs. And so proton therapy as a form of radiation does work for prostate cancer. In fact, we do treat prostate cancer patients with proton therapy. Proton therapy also works for every other form of cancer where radiation is indicated. Now, for prostate cancer specifically, here at KU, we offer a range of different radiation options, from proton therapy to seeds, to SBRT, which is a very short 1-week form of radiation for early prostate cancer. And really, I think the importance of seeing an expert is that we will see exactly how aggressive the disease is for a particular patient, and then we'll match the right treatment to the right patient. And proton therapy is something that we discuss with many of our patients who come to see consultation with us.
Just out of curiosity, of the patients you decide to have radiation therapy on for prostate cancer, what percentage are going to have proton, what percentage are going to have other forms of radiation therapy?
I would actually say probably, again, because here at KU we offer all the different types of radiation. If we just offer one type, then all the patients will get the one type, but we actually offer all the different types of radiation, and we discuss the different options. So just sort of very quickly, if a patient is eligible for prostate seed treatment, that's just a one-day, one-time treatment, and that may be appealing to a lot of patients. We also have for early prostate cancer, a treatment that's just 1 week, 5 treatments of radiation. Proton therapy would be a treatment that's about 5 or 6 weeks. So offering the different options and matching it to the particular patient's diagnosis, I would say probably maybe half or more of our patients ultimately choose something other than protons. We would offer it to patients where they're eligible for protons, but when they hear, well, if protons are 5 or 6 weeks, if I'm eligible for a 1-week treatment, sometimes patients choose that, and so we're able to have that discussion with our patients.
Pretty great stuff. And Dr. Parker, you obviously your approach is more surgical. Let's remove it. How do we know when to do surgery, when to do radiation?
A lot of the times it's up to the patient. So the decision on a treatment is driven by the side effects of therapy, less so the cure rate. Because when we abide by kind of guidelines in evidence-based medicine, the cure rate is going to be identical with a surgical-based approach or a radiation-based approach. And so then it really gets down into understanding what are the patient's needs, what are their values, and what are they willing to accept as a part of their treatment, and then driving towards that goal.
And there are complications to both procedures.
Correct.
Yep. So now you've got a new thing you're going to talk about. There's a certain type of tissue-sparing surgery. Talk to us a little bit about what that is.
Absolutely. So that's called a space of sparing surgery, which is a modification of how we do prostatectomy, or removal of the prostate, that preserves a lot of the surrounding support structures for the bladder. And what it does, it expedites urinary recovery. So one of the big side effects of taking out the prostate is incontinence. And most men experience incontinence for a period of 3-6 months, where they're having to wear Depends or diapers, pads. When we do surgery with this method, men are dry often the day their catheter is removed. So very, very quickly, it's a very natural form of continence, much like you would have today, where you don't necessarily have to think about your urinary control, you just have control. And so it's one thing that we offer, much like Dr. Chen was saying, when you specialize in a disease and that's all that you treat, you actually are able to expand what you offer men and offer the entire breadth of options. Certainly not appropriate for everybody because it's saving tissue, higher risk disease, higher grade disease. It's less likely to be appropriate because it may put them at risk for a recurrence that could otherwise have been prevented.
So when you guys look at these kind of diseases, that we know that there's incontinence is one challenge. Another challenge to men is their sexual health after this.
Oh, yes.
Talk to us a little bit about that for both radiation and for surgery. You go first.
Yeah, so sexual health is a huge part of prostate cancer treatment. We often think about it as just erectile dysfunction, but there's also ejaculatory loss. So the prostate makes all the fluid in ejaculate. If we treat the prostate, it doesn't matter, surgery, radiation, men lose ejaculation. And so sexual dysfunction is a part of prostate cancer treatment. Erectile dysfunction, which is the one that we get most distressed about because the complete loss of the ability to achieve an erection, is common with surgery, at least temporarily. It's common with radiation when it's paired with hormonal therapy, and it's an issue that has to be addressed during the recovery. Thankfully, as part of our program, we have specialists who also specialize in the survivorship needs of these men to get them the care that they need for their erectile dysfunction with either medications, surgeries, other treatments to restore their sexual health.
That's a big deal, Ron. And I suspect that you have some challenges with that with radiation, or how does that look?
Yeah, absolutely. I think we do counsel patients before treatment about the different side effects that are possible. And I think, as Dr. Parker said, both surgery and radiation can cause sexual dysfunction. And as he said, we discuss that up front. Patients, now, not every patient will have erectile dysfunction after treatment. Some patients will, not everybody will. For those that do experience that after treatment, whether it's surgery or radiation, we have great experts that can really talk to patients through the different treatment options for sexual dysfunction. And I think that's part of the comprehensive program that we have here.
So if we look at this special kind of sparing surgery, this Retzius thing, I think we have a clip up there around to show for it. What are we looking at?
So right now what we're looking at is the back of the bladder. So normally when we remove a prostate, we actually have to take the bladder and move it out of the way. So we destroy all the support that the bladder has to the abdominal wall. When we do surgery in this fashion, and what I'm doing right here is I make just a little bitty window in between where the rectum and the bladder is and remove the prostate through that window. And by doing that, we're preserving, again, all of that support tissue and leaving the bladder in its normal anatomic position.
And the prostate's that kind of white thing in the middle there, is that right?
So the prostate's actually on the upper edge of the screen, and what I'm doing, at least at this part, is releasing the rectum from the prostate.
Okay.
The prostate now is the part that's kind of hanging down in the middle of the field. What I'm doing at this part is releasing the bladder from the prostate.
Okay.
Again, normally that's done in a way where we've really destroyed all the ligaments and support structures that help support the urethra, help support the bladder. At this point, I'm truly separating. In a second, you'll actually see the inside of the bladder because the prostate is a part of the urinary tract. And so once we separate that, we're able to release the prostate from its surrounding tissues and, again, leave everything as it's meant to be.
Okay. Wow, that looks pretty detailed, and you spent a little time trying to get it right.
Just a little bit.
All right, that's awesome. All right, Alexis, we're going to turn to you next, and I think we have some questions. If you do have any, remember to send them in to YouTube, Facebook, Twitter, or email the Medical News Network. But first, we're going to check with Dr. Dana Hawkinson, Hawkeye, COVID count.
Yeah, hi. Yeah, I know for me, when I was choosing my urologist, I made sure that they had small hands. So that is a very important point, just as you guys were talking about. Extremely.
Yeah.
So, right now, COVID counts looking good. We have been down in those single digits. I think that's a good thing. Those single digits for active cases. We have 15 total, 6 active, 0 in the ICU or on the ventilator. So we are going good. I was asked to prognosticate, and I'm being optimistic, but I'm hoping and believing we can stay in those those single digits of active infections for another 4 or 6 weeks at least, or even longer. But we know that we either are in respiratory viral season or coming out of it or going into it, and soon we will be moving back into it.
Yeah, come fall, I think those numbers will kind of perk back up again. People go indoors, and the new variant will be out here. I think this the new Omicron out there is probably going to be surging a little bit in the fall. Looks like they're going to try and change the vaccination around a little bit for it.
Yeah.
But whether it's Omicron or Alpha or Delta or what's it, in the long run, this long COVID syndrome, Hawkeye, is a challenge.
Yeah, absolutely. We know that this is going to be, it really has become a chronic condition. Much like things like high blood pressure, hypertension, diabetes. It does affect people's quality of life and the their daily activities, all of that. It can reduce work time. It can reduce your ability to take care of your kids. So it is a very serious condition, and it affects different people in different ways. Even if you haven't had severe disease, you can still get effects of long COVID. Right now, we know the government is working to, number one, help define it. Number two, figure out how and what is going on to cause it. And also, of course, most important is the best way to manage it and treat it.
Yeah, as we think about long COVID, it can be hard to define what it is. The New England Journal of Medicine last week had 3 different articles around, sort of focused around, one very specifically focused on long COVID and COVID in general. So let's talk a little bit about that. It's hard to define. The NIH is studying long COVID through its Recover initiative. And this month, the researchers with Recover released a symptom scoring system to determine when someone has long COVID specifically. And the reason it's hard is because it's a little fuzzy sometimes. And the reason it's fuzzy is people it can take a while to recover from a viral illness in general, COVID in particular, and then there's long COVID. So talk to us about some of those symptoms, Hawk.
Yeah, again, a lot of it is subjective. So when it is subjective, we do talk about symptoms as opposed to other things that we can identify, like blood pressure and lab results, which are objective. But you can see here in this graphic, there are so many symptoms. What we talk about probably is the most common symptoms are things like brain fog or decreased concentration, continued shortness of breath, just overall weakness or fatigue as well. Those seem to be the most common, but as you can see in this graphic, there are so many different ones, and it's hard to gauge those and understand those. So a lot of these symptoms are subjective, and then it's also unclear exactly as to what is causing it. Is it because you had this viral illness more than 4 weeks ago or 6 months ago, or is it another cause? So it's really important to try and elucidate or identify maybe another cause of some of these symptoms, because if you are coming into your doctor and having a complaint, I don't think it's appropriate just to chalk it up to long COVID. You need to really go and understand, is there something else going on?
So I think the way I would look at this is that it is still one of the leading causes of concern around COVID and disease in general in the United States. If up to 10% of patients have long COVID, that is markedly higher than what we see with other diseases and our other viruses. And to think some of these people are now being disabled, and there are now criteria specifically for COVID disability. So this is a real thing, and if we don't pay attention to it, I think it can snag folks a little faster than they want to admit.
Yeah, absolutely. And one of those things that the article talked about was who is bearing the brunt of that patient load, and it is typically those primary care providers. We know here at the health system, our long COVID treatment, we did have a specific virtual clinic, and that was to expedite your entry into seeing a specialist for whatever problem you have. But we know that here at the health system, Dr. Brandon Comfort is really running a lot of that and dealing, and I know his colleagues in primary care, certainly for the cough, the shortness of breath, it's Dr. Leslie Spikes in pulmonary, one of your colleagues as well. It is these groups of physicians that are really going to be bearing the patient load brunt, and that can be frustrating for a patient as well, because it may take time for them to get in to be seen. But then if you go out to the rural areas, and we know that certainly Kansas has a lot of rural areas that need to be managed and need to have health care delivered to them, and so you're really going to see a lot of those nurse practitioners and those primary care physicians out in those rural areas who are going to be having to take on an increased patient load with these symptoms and trying to manage that as well. So one of the things with the NIH is really trying to determine what is the best therapies moving forward and what can we do to help, number one, define, but also develop therapies. But then also, as far as protecting against long COVID, we know that vaccine does help protect against that. That can reduce your risk of long COVID. There was a recent article looking at the ability of metformin to help reduce that. But there are caveats with all of that as well. So we are also looking at ways to help reduce your chance of getting long COVID after getting acute COVID as well.
All right, thank you. And clearly, the best of it, the best plan here is prevention.
Yep.
So, all right, let's get community questions from Alexis Del Cid. Alexis, how are you?
I don't hear.
Hey, we
of
can't.
prostate
There you go.
cancer.
Start
Carrie,
over there, kid.
Well, first of all, I love that you called me kid.
Thank you.
Now you're my new favorite
Youngster.
person on earth.
You're so young, I know.
We're getting some great feedback, is what I was saying, on the topic related to prostate cancer. Our viewers are so appreciative. Carrie just shared, this is very helpful information. We're going through this with my dad, and we're trying to figure everything out. Then we have a question from Sally. Sally wants to know, can untreated STDs contribute to prostate cancer?
Team.
No.
No. Okay.
Okay.
All right.
Cut and dry? No.
Cut and
I have
dry.
a
Well, that's
question
probably
from-
good news for some men.
Yeah. Still get them treated.
Very good news.
Yeah, get the STD treated. Different challenge if you don't do that.
I wonder if that question was sparked by HPV can cause cervical cancer in women, so people were
Yes.
wondering that with prostate cancer.
No, it's a great question, actually.
Sean has a question. Sean writes, I have a yearly physical. If my PSA has always been normal, should I have any worries? If my PSA is normal, is there a need for a physical check of the prostate by my doctor?
I'll start. So, yeah, I think the answer is yes. The digital rectal exam to feel the prostate is still a very important part of prostate cancer screening. I think it's great. And the reason you need both the blood test, PSA, and the exam is because neither is perfect, and together they're better. There are men who have normal PSAs or even low PSAs where the doctor has felt a nodule that led to a prostate cancer diagnosis. And so even if the PSA is normal, which is great news, there is still some portion of men that have prostate cancer that can be felt on exam.
Yeah, I think it's important to recognize about 10 to 15% of prostate cancers don't make PSA. And so this is one of the reasons why PSA, while it's a good test, it's not a perfect test. And feeling the prostate can help us identify some of those men who have PSA poorly producing cancers.
10 to 15 is
Alexis.
a pretty significant percentage, 10 to 15%.
It is.
Terry has a question. This is a great question for those of us who don't have a science mind like you doctors do. Terry wants to know, how does the proton actually kill cancer? What does it do to the cancer?
Yeah, that's a great question. And so proton therapy and also other forms of radiation that we use, the way and I think it's important because sometimes patients ask me, it's a way to kill cancer. It's not just a way to treat cancer, but it's actually a way to kill cancer. And the way proton therapy and other forms of radiation kill cancer is by basically killing the DNA of the cell. And so when proton therapy goes through a cancer cell or when other forms of radiation goes through a cancer cell, it basically causes DNA break in the cell. And as people can understand, once a cell no longer has a working DNA, the cell will naturally die. And so that's how proton therapy and other forms of radiation kill cancer.
Yen Liang has a question. This is a complex question. It's a good one. Yen would like to know, he writes, I would like to inquire about the advancements in new surgical techniques for treating prostate cancer. And doctors, you touched on this a little bit. Yen wants to know, have there been significant improvements in addressing the side effect of retrograde ejaculation through current surgical methods?
Well, okay, first of all, you're going to have to talk to everybody about what that is.
Absolutely.
I don't know what that is
How
either.
to treat it.
Yeah.
So retrograde ejaculation would be when a man achieves an orgasm, instead of the ejaculate, the fluid expelling forward, it expels into the bladder. With prostate cancer treatment, there is an ejaculation, so no ejaculation, because the glandular part of the prostate, which makes that fluid, will die, either with radiation, because the radiation will kill the glandular part of the prostate, or with surgery, because it will be removed. So to answer the question very specifically, while there have been advances in surgical techniques and radiation techniques too to improve quality of life and outcomes, ejaculatory dysfunction is a uniform part of prostate cancer treatment, unfortunately.
Yeah, and just to add to that, I mean, so I think what I often tell patients is if you have your prostate cancer treated, surgery or radiation, you will be dry in terms of ejaculate afterwards. Now, many men can still have the sensation of climax, but the fluid really will not be there.
So it's going to feel different.
Correct.
Yeah. Yeah, but if you survive, that's an okay thing. It's kind of like saying, well, I want to keep all my sexual function intact, but I also don't want to die of prostate cancer. Those two things can be in conflict.
Lynn has a question. This is interesting. Lynn wants to know if doctors ever disagree on when prostate cancer needs to be treated.
Yes. So, prostate cancer, and I think if you think about a lot of things in life, there are situations where it's very clear something needs to be done, and there are situations where it's very clear something doesn't need to be done, and then there's this huge block in between where it's kind of gray, not only when should prostate cancer be treated, but how it should be treated, what the compilation of treatment should be. And so, going back to the point about second opinions, this is the value of a second opinion. A lot of us will debate or have differing opinions about what should or could be done, and hearing the complete spectrum of options is very important.
So I remember when I was first diagnosed with prostate cancer, I think I tried to talk you into taking out my prostate, and you were saying, no, I think you do fine. And thank God I listened to you, because, and my wife is always like, you need to listen to him, because I was like gung-ho and getting it out and didn't. And I'm, whatever number of year, long time into it. And man, you think about the side effects and the challenges, and a couple things happen. First of all, there are better surgical techniques that come along. That's a good thing. And second of all, you don't have any of those side effects. And it's pretty clear that there is this class of prostate cancer surgery patients, or prostate cancer patients, who do okay over the long term, as long as you are followed closely. And so you don't normally think about that as the approach to treating cancer.
Correct.
But in this case, it can be pretty successful.
Absolutely.
Yeah. And then but when do you say, I need radiation, and surgery is not the right way to go? Ron?
Well, I think Dr. Parker alluded to this, but for the majority of men with prostate cancer, surgery and radiation are thought to be equivalent options in terms of curing the cancer. And so for the majority of men, we talk about the surgery option, we talk about the radiation option, and really, I think our program is set up where a lot of men see both Dr. Parker or a urology colleague and a radiation oncologist, so the patient can really be educated about all the options, what the treatments include, what the side effects are, and then they can make a decision. So for the majority of patients, they have both options. There are some patients where surgery may be better and radiation may be better. I think that those are the smaller portion of patients. So, if patients are older and have other medical problems, maybe surgery is less optimal for them, and then radiation may be better. There are other patients where, if the prostate's really big or they have a lot of urinary issues at the beginning, maybe radiation will exacerbate that. So there's some nuances here, but for the majority of patients, they really should see both and talk about all the options.
All right. Alexis, back to you.
I have one last question. This one is from Rachel. Rachel wants to know, are there specific side effects or possible side effects of proton therapy for prostate? And what are those side effects?
Yes. So proton therapy has side effects. All treatments for prostate cancer have side effects. Proton therapy can cause some side effects related to bladder, so some urinary irritation, and potentially can irritate the rectum, although now we have something called a hydrogel that protects the rectum that reduces that. But irritating the bladder, causing some bladder side effects, and maybe the rectum, and also sexual dysfunctions we talked about, those are some of the possible side effects proton therapy can cause. Now, having said that, there have been lots and lots of studies published looking at how men do with proton therapy for prostate cancer. Even though I do think all men will have some side effects, it is a very well-tolerated treatment.
All right. Well, I want to thank all of our guests today. This has been an outstanding discussion, and I'm grateful to all of these good folks for being here, and I'm grateful to Dr. Parker for being being my physician. I want to hear some final thoughts before we go. Let's start out at the Proton Center. Sarah, what are your final thoughts today? And thanks for being part of the program.
Yeah, thank you for having us. Final thought is I'm just grateful to work with amazing patients, coworkers, and a health system that continues to fight really hard to win that battle against cancer. So.
Thank you. And Kathy?
And yes, and I just want to say, if we can be of assistance to anyone that is looking for a second opinion or just to transfer their care or newly diagnosed, please feel free to give us a call at 913-588-3671, and hopefully I'll be your nurse navigator.
All right, Sarah and Kathy, you guys are awesome. Can you come back on the program? And I want you in the room. We'll push these guys out. How's that? Was that a deal? All right. Thank you guys so much to all the great work you
sounds
do
like
to
a
all of our
plan.
nurse
We're in.
navigators. Yeah, it is a win. All right, Dr. Parker, final thought.
So first, obviously, thank you to the nurse navigators. Patients feel so welcomed into the system by interacting with them first. But probably the most important thing is that prostate cancer is an incredibly treatable disease when caught early. It's very important to do screening. I can't stress that enough. Men need to be advocates for their health, get their screening done so that if we can diagnose it early and get it treated early.
All right, thank you. And thank you for being here, and thanks for being a great person, great physician. And the same thing to you. Thank you for being a great person, great doc.
Thanks.
Final thoughts.
I think it's important to make people aware that tonight's Royals game is dedicated to prostate cancer awareness. So we're trying to, Dr. Parker is going to throw the first pitch tonight, and people should turn out to watch his
Oh, they
first
should
pitch.
duck is what they ought to do. He's over here talking about how hard it is to practice.
Yeah.
He's having a hard time.
There's also an effort to get, prostate cancer patients, survivors, families, advocates to turn out to this game. And so we're partnering with the Prostate Network, which is a big advocacy group here in this area, and to try to get people to turn out. It's really great that our partner, Royals, is doing this for prostate cancer. This is such an important issue. Men need to be screened and come out and enjoy the game.
That's a great segue. We'll come back to that in just a moment. Dr. Hawk, final thoughts.
I think it's all about prevention and screening, just as we heard Dr. Parker answer that question about do the STDs cause prostate cancer? No, but they can cause chronic long-term problems for both men and women, so it's vitally important to go get screened for STDs. Also, as far as prevention, there was a question about HPV in there as well with cancer. Certainly, I know it is very important that if you are of that age and in those, for that recommended HPV vaccine, and especially if you have children, please get them vaccinated against HPV. It can protect against cancer. I know certainly in my HIV, my men that I treat for HIV, we do HPV cancer screening as well every year. So that is vitally important as well. So continue to be up to date with those vaccines, both childhood preventable vaccines and any up-to-date vaccines that you may need as an adult to help prevent some of these things as well.
So I'll be out at the K tonight as a cancer survivor, and that feels good to say. It wasn't good to hear the word cancer a few years ago. But when you come to a place where folks have both a human touch, a medical touch, and a scientific touch, you know you're going to get the right touch. And you think, these guys are so highly specialized in their areas. You think, is that the right thing? I would ask you this. Do you want to have both Travis Kelce and Isaiah Pacheco and Patrick Mahomes on the same? Of course you do, right? Everybody's got their role. Everybody does their jobs. And I think when that happens, you can get the best possible outcomes. And I think every day these guys win the Super Bowl, and we're very grateful to have them there. So thank you for the great work you do. Thanks for taking great care of our patients along with those nurse navigators. And remember, faith, hope, and science, again, that's what helps keep us safe. It's what helps keep us well.
Coming up Friday on the Morning Medical Update, dads should celebrate as many Father's Days as they can. That's why staying on top of your health is so very important. I'm Jessica Lovell on the next Morning Medical Update. The importance of the annual wellness check, why men need to honor and celebrate their doctor's visits just like any other holiday. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.